We want to give everyone a happy Trisomy 9 day. I'm John Carey, one of the medical advisors for SOFT, and I'm honored to have two colleagues join us for the panel, Dr. Mindy Lee and Kelsey Hogan, who is a genetic counselor. They're both at Lurie Children's Hospital in Chicago and are joining us tonight for our Trisomy 9 panel. So I think the three of us were quite impressed with the fabulous questions that came in. We're going to do our best to answer as many as we can in our remaining roughly now 55 minutes. But they are, I said to myself when I read them, Dr. Lee, that these are like questions from genetics fellows or primary care doctors in the community. They were very profound and excellent questions. So we will do our best. If there's a question we don't quite answer, we do have those that submitted their questions, their emails, and the three of us can try to figure out a way to answer those questions that are only partly answered or not answered very well tonight, or weren't answered at all, by email for those that sent the email. So I'm going to start with a question from Alyssa about Gabby. I'm going to read the entire question for Kelsey and Dr. Lee's benefit, and then turn it over to them to attempt to answer the questions. And we're going to try to stay on time, so we might shorten some of the questions to move on to another one. So Alyssa writes, Gabby, who is 2.5, has chronic constipation to the point of impaction and 2 bowel cleanouts in the last few months. She also has a diastasis recti, which is a separation of the abdominal muscles so that you can actually see the tummy protrude out. Her bowels were super dilated on one of her first x-rays. We are currently doing an adult dose of Miralax a day, and she still has moderate stool burden, even though it's liquid blowouts typically every day on the last x-ray. Thoughts on a course of action? Thoughts on diastasis recti closing or having a surgical repair? So Dr. Lee, you went to, if you can, I can repeat some of it. The adult dose of Miralax, the chronic constipation, moderate stool burden, and thoughts on course of action.
Yeah, no, I actually pulled up the questions on my end as well, so that we can save a little time for not having to read questions. So thank you. So really good question. So, constipation, I would say, is something, it's pretty common even just in our general pediatric population, but it is, also something we certainly see in genetic disorders. I have seen this reported in some patients who have this, who have T9M. I will say that does sound more severe than, let's say, it's not like a common thing, I would say, for example, that we see this reported so much. So, I think in medicine, we always ideally like to first try and do what we can supportively, of course, to avoid surgery if needed. That being said, if surgery is needed, that's something to consider. But, I guess in this case, ideally it would be nice to see, for example, if there's other things that you can do before reaching that step. So for example, it sounds like if there is some significant diastasis recti, sometimes there are supportive things with like PT and things that you can do to try and improve the musculature there. You may not be able to fix it completely, but that might be one route to try just to see if that kind of helps kind of close anything, kind of improve the sort of musculature and strength in that region to see if that has, that may or may not have a direct impact actually in the stool. Leading to my second thought of, well, I think, if this is something that, let's say you address, some of the, the strength and tone and things that are in that region, and you're kind of maxed out on your medical therapy. I think the question is, has everything been kind of looked at aside from just, the work in the workup of the constipation is sort of my thought. I'm not sure if, what specialist or what degree of specialist that, she's seen or the patient has seen. But that might be another, you know, route to try, if, since it sounds like this is not necessarily working so well. I don't know, Dr.
Right, because
Carrigan, or,
sometimes, Dr. Lee, there are pediatric GI docs who
mm-hmm,
really kind of specialize in bowel lack of motility problems.
yeah.
You know, as an area, like at our children's hospital, we have such a person. So that was kind of what I thought you were thinking was a maybe next line of possibility.
Yes, that was my exact thought. And Dan, I'm not sure exactly what specialists have been seen, but there are definitely specialists who are in the peds GI world who have those have that area of expertise. And yes, depending on where you're located, there may be a specific like motility clinic as well.
Right. And in fact, Alyssa's second question, which is also somewhat GI related too, and maybe addresses partly what we're talking about, and maybe you could see it up there. She's getting celiac serologies completed in the coming weeks.
Yeah.
We had a consult with Mayo. It mentioned during that possibly getting worked up for Hirschsprung disease, which maybe goes back to that question of bowel dysmotility to some extent. And then Alyssa's asking, should we get worked up for this?
Yeah. Oh, yeah. I'm sorry. I didn't realize that the same question had come from the same family. I wasn't looking that far on my screen. So yes, no. So that does kind of link into what I said before about, you know, when I think the typical presentation, of course, of when a child, let's say, stooling regularly, or they're having stools that are, you know, not soft and regular, that kind of thing. You know, the initial workup typically is, of course, for constipation, but there can be some other, you know, more rare causes of things that are kind of contributing to that picture. And so, you know, again, this, at least for T9MM, you know, it's certainly not like a majority of children that we're seeing that have, I would say, constipation to this degree. So it's worth, I think, you know, and sometimes, you know, you can have multiple things. We have definitely seen it in the genetics, just being in practice, where, you know, there can unfortunately sometimes be sort of multiple sorts of diagnoses ongoing. Not that that's necessarily something we're searching for, but I think the general thought is that, you know, this does seem a little bit more significant. We want to make sure, I would recommend that, you know, nothing additional is just being missed in terms of like the workup. We probably basically would recommend kind of as more thorough workup as possible. And that could include things that are listed here. And, you know, celiac is an interesting one as well. That is something that, that is not something I will say I've seen like commonly at all in this population, but it can happen though, just in the general population as is. So that's why it's not out of the realm that there could be, you know, kind of a couple of things going on. And that's why I think it's still fair to do additional workup for it.
Right, very good. And in fact, I was going to ask you the same question. I didn't remember seeing, like, we know that celiac does occur with increased frequency in Down syndrome. It's actually famous with that connection, and also in Williams syndrome. I hadn't read about it in, you know, 9p trisomies of any sort, but that's why I was glad you addressed that question. What about Hirschsprung? Have you seen Hirschsprung, which maybe you should define that too. Have you seen Hirschsprung in kids with T9 mosaicism or partial 9p?
That's a good question. Off the top of my head, no. I have not personally seen that, but then again, that's not out of the realm of it
Right.
happening just by
Right. Yeah,
chance. But yeah,
I
no,
haven't I haven't seen
not
it either.
personally.
You
No.
know, Hirschsprung does occur again, interestingly, coincidentally, if you will, in Down syndrome and other syndromes we see. And if you don't mind, just we'll go to the next question, but can you just let the audience know what Hirschsprung is, just for everyone's benefit?
Yeah, so Hirschsprung's is, as you might guess, a condition that affects the GI tract, the gastrointestinal system, basically affecting kind of the larger part of your intestine, the colon, and so you have nerves and things that control the muscle and things in there. So basically, when there's nerve cells that are or building blocks there that are missing or abnormal in that section of the intestine, it basically prevents the stool from moving the way it's supposed to. That's how it can lead to kind of a number of GI complaints, and basically stool not moving forward the way it's supposed to.
And you can see if there's discussions about Gabby having fairly severe constipation and in a, the emotal bowel issue that someone might move to, well, maybe there are nerves involved at the very end or maybe along the colon, so you can see why that question might come up, even though I'm not at all convinced that's where we'll be ending up. But I think in our interest of doing the best we can, I'm going to move to our second question. And Kelsey, I'll have you address this if you can. And Emily Claire asks the question, how are genetic counselors involved in supporting families impacted by trisomy 9?
Well, that's such a good question. I think we are a part of the process at various points. So depending on how or who gave you a diagnosis of trisomy 9, sometimes a genetic counselor is there as part of like a prenatal team, if you've gotten a prenatal diagnosis. Otherwise, and once babies are born, sometimes we are there inpatient. So like as part of like a NICU team or the genetics team that comes and visits babies in the NICU and are helping disclose results. So we're kind of sometimes part of the results disclosure piece and educating about what is trisomy 9. Trisomy is a word that you don't generally learn about in school because people don't usually refer to Down syndrome as, let's say, trisomy 21. But providing education is definitely our biggest piece, especially whenever you receive the diagnosis. But we're there after the fact too. So usually we're trying to be a part of the care team and partnering with the doctors and helping provide support throughout not just the first appointment, but throughout a child's life. Being maybe the first person that you reach out to if there's a medical question. I don't know how many of you are able to just reach your geneticist right away. Sometimes you have to go through your genetic counselor to help ask some of your medical questions and kind of figuring out, some pieces of a medical mystery is starting with the genetic counselor before you even get to talk to your geneticist. But we also help advocate for children who have trisomy 9. That's why we're here. I'm here today because this is a wonderful and supportive community, and just long-term support. The last piece I will say is that sometimes we're involved in the like reproductive planning piece. So if, let's say, a family is wanting education of like if this could happen again. So really a lot of different touch points that you can see us working with families and supporting families who have a child with trisomy 9 or mosaic trisomy 9.
Thank you, Kelsey. And as someone who can say that I've been in the field, I won't say how many decades, but more than 4, I can't even think of genetics clinic without partnering with the genetic counselors I've worked with for all genetic conditions, including trisomies. But thank you. So the next question comes from Brianne, and she's asking, evidence of early aging or Alzheimer in trisomy 9, T9, well, we could include partial 9 trisomies too. How to prioritize developmental therapies, social speech, PT, OT. So kind of 2 questions. One is evidence of early aging, and number 2, prioritizing developmental therapies.
Yeah, good question. I have not seen any specific evidence of this specifically for, trisomies of any variation in chromosome 9. Caveat here, though, I will say, is that we don't have a lot of information on the adult population who have changes such as these. So for example, even in my clinic so far, we have not evaluated any adults and we know of, and from what I've learned from even just working with the community, that there are multiple adults that do that are alive and such. I just haven't evaluated them personally myself. So I think there's definitely, this is part of the reason actually why we want to do some longer term studies on these individuals as they get older to see if there actually is information there specifically about that. Yes, and regarding the developmental therapies, honestly, just being in practice, I've seen the therapies are always helpful as long as they are working for the family and the patient, and they feel that the patient is making progress. Especially when individuals are younger. Certainly, I feel like that's when you can see the largest changes. And responses sometimes to therapies, but that doesn't mean that the therapies don't help at an older age as well. For that as well, for example, same thing. We don't have information about that. We don't have specific studies that have looked long term at older and adult individuals to see, like, did it make a difference for them to continue? I think it's one of those situations where I don't think it hurts, certainly. But at the same time, recognizing that it takes a lot of time and effort and sometimes money, of course, depending on your insurance and situation, to continue those supportive therapies for such a long period of time. I think for older individuals, I think, if it's one of those things where it seems like there's just not much more benefit or change at that point, then I can see why, it's not necessarily worth kind of continuing, forever, so to speak. That being said, though, for other individuals, maybe it would actually still continue helping. I don't know, Dr. Carey, if you have any other additional thoughts as well from just kind of experience, also even just with the other trisomies. And I feel like a lot more known, for example, with some of our other trisomies and some adults, well, trisomy 21 at least, or Down syndrome.
Right. And in trisomy 21, the reason for the predisposition to an Alzheimer, and I'll call it an Alzheimer-like condition, in people over 40, 50, 60, probably about 25% of them, is because there's a gene on the 21 that's probably the amyloid-related gene that's probably the basis for that in Down syndrome. So I don't think that it isn't like all, any of the other trisomies or chromosome conditions in general have a predisposition to Alzheimer. It's pretty specific because of the genes on the 21. So, but it's still an important question because we hear about it a lot in Down syndrome, so it's logical to then ask the question in T9 of whatever variety. But the next question is from Cheryl Lynn, and it's a very specific question, but I know it's an important one. Soft tissue challenges ligaments and tendons in a 25-year-old male, impacting ability to bear weight in knees and hips. Are there any treatments?
Yeah. So definitely musculoskeletal, basically the parts of the body kind of dealing, with your limbs and your muscles and things can be affected. I'm hopefully interpreting this question correctly, in that it seems like there's maybe weakness to the point where there's just some difficulty here in bearing such. I think it's a little bit hard for me to give like a specific response without knowing a little bit more details, like in terms of, the degree of, mobility here, or lack of that as well. Typically, depending on if there's weakness or some difficulty here, typically there's always supportive things, which, I presume maybe has been tried or not. With things, with physical therapy and occupational therapy, in this case, probably more physical therapy, just kind of based on where those joints are, supportive things there. And then, there's a lot of options when it comes to like bracing and orthotic support and things like that. Those are, and other kinds of devices, I would say, that I think I've seen, that patients and families have working with the orthopedic specialists. Those are typically some of the first things that are done to try. Now this patient is now an older patient, but I'm not sure of the size his size as well. So, I think those are kind of my initial thoughts. I apologize. It's a little bit hard to get a little bit more specific about that without a little bit more detail about what's actually going on.
But I think the one thing that we could say when you were mentioning the PT is, I think, 10, 20 years ago and earlier, we tended to put people on, excuse me, on rest, when in fact, I've heard PTs appropriately say, the motion is the potion, or the lotion. So that, in fact, I think most of the time, can't say for this specifically, most of the time, PT has a place here. So Dr. Lee and Kelsey, let me, I should have included Patricia's question with the question about Alzheimer's, because they're both related to adult care. I should have paired them up, but I'll ask Patricia's question because you've already partly answered it. Her question is, what, if anything, should parents of older T9 mosaic children, adults look out for?
Yeah, that's a great question. As I mentioned, we know that there are individuals who are adults, with these conditions. They have not been fully long-term studied, which is why we are trying to do that now as our patient group grows up. So, I think it's hard to say precise things to look out for. However, the things that happen in adulthood are, there are some things that overlap. Is the same things that were looked at in children, when individuals are children. So, so one, as patients grow up, they still need the equivalent of a general medicine doctor, the way that all your children have had pediatricians. Someone just general to look out for the general things that may happen as they get older. We don't have a lot of we don't have the long-term information about, for example, are there changes to individuals like hearts and kidneys, and as someone already mentioned, the concerns possibly about changes in the brain and things like that. That being said, I think if I was, they follow adults into adulthood, I think that is something, periodic screening for some of these things, I think, is likely going to make sense. But, how frequent and when, we don't have the info yet, I think, to say. But that is likely something that I'm hoping to kind of learn as we follow these patients. But we say similar kinds of things, for example, for conditions where we don't have a long-term, a lot of long-term information, where, it's a little bit of, okay, what are sort of the most important body systems that could possibly be affected? And, you kind of try to do your best to monitor some of those things long-term. So ideally, I think as we kind of learn a little bit more about this, we would like to put together some more longer-term screening guidelines for some of these things. At the moment, though, it is not based on something specific, though, in the sense, again, we just don't have a whole lot of data or information to pull together. But I suspect that was part of the reason why we tried to kind of start some of the research we have and kind of centralize and, offer clinics and things like that. So we can learn along with everyone. So those are kind of just a few things that I think will be likely helpful to look at down the road. I just don't know how frequent. And then, of course, from a neurologic standpoint, in terms of like development and how people have been progressing, that's another thing I think we're going to have to be just kind of charting and watching to see if there's some other things that we learn from patients as they get older.
Wanted to add just one thing is that, Dr. Lee and I say this to many of our patients where they have newly described genetic disorders, or we just don't have a lot of data, is that we don't go away as a genetics team because we want to be the ones periodically checking in and suggesting things, new screenings based off of what new literature comes in. So that's partially why, going back to the last question about how do genetic counselors be involved in this, is that we're kind of periodically involved throughout the years, touching on things that come up over time. And because it's not just a one and done appointment, we like to follow families over time for this reason.
Yeah.
And
also,
Go ahead, you go, go ahead.
Oh, no, I was just going to comment because I know I know it can be, as a family, it can be so difficult and frustrating, like not to have the information now. I will just say from being, because it takes so long for things to kind of get published from our end, like in the scientific world. I mean, it can just take years, but because we are trying to focus our studies, on sort of these groups of conditions, we're hoping to, as we learn things, and as we kind of internally learn things, we'll hopefully be the ones to be able to start making some of these recommendations, let's say even like sooner, for example, than before things actually get formally published out there. But, it's something that we have to develop based off of, appropriate research and from, wonderful families like yourselves who are interested and willing to participate and share this information and things like that, because we can't develop these things without that at all.
Thank you. And following up on what Ms. Hogan said, in terms of we don't go away, I think that one of the benefits of the periodic visits, even into adulthood, is that we as clinicians and providers, before someone comes to clinic, it's our job to review the literature prior to that visit. And you guys are doing this all the time in T9 conditions, but to review the literature, and then is there something new since the last visit that might come up, some new risk we didn't know about that seems real. But anyway, thank you for those comprehensive responses. So Dr. Lee, I'll pose this question to you because it's always timely. I already mentioned that Scott asks, is there a growth chart for trisomy 9 children?
We are working on it. Yes, no, short answer is we are aware of the need for this. I know it's difficult with rare diseases when, individuals are being placed on growth charts that are not necessarily meant for individuals who have specific unique conditions. And so we have some families who, have already provided some basic data. The thing about this, though, is that in order to make a growth chart, we want to have as many data points as possible. And so, we know kind of with this, and actually with these particular groups of conditions, I know there's multiple families on here who are, who actually have some slightly different variations. It sounds like of trisomies of chromosome 9, because the group that I was actually, for example, initially was working on was specifically for the trisomy 9 or trisomy 9 mosaic patients. But I know there are other trisomy variants, basically. And so those patients are slightly different, essentially. And so you have to be careful about grouping the patients together to make sure you get something that's in line with the same diagnosis, the exact same diagnosis. So that's actually the tricky part of why it's taken a long time to get the data together. And so we're still gathering it. Basically, we have now a number of families who have agreed to participate specifically in our trisomy 9 study. So we are, I'm basically still in the process of gathering the data for that, with the end goal to, once we get enough, to be able to publish and do one, and to actually have a formal one for that. And then depending on the number of variants that we can see, because we're kind of starting to, study kind of some of the other trisomy variants as well, we may be able to get to numbers to do that, but I'm not quite sure yet. And that's all just going to depend on what we can, the amount of data that we can get.
And so, Mindy, just so it's public, as you know, some of the families on this call put together growth measurements of their young people with T9 mosaicism specifically, and I had that flash drive sitting right here for too long of a period of time, and fortunately I gave it to you, so you now have that flash drive with the beginnings of data, so hopefully will be the nidus to continue. So I apologize for the fact that until I met you and until we worked, till that came about, that I was kind of, holding it here thinking, well, we'll figure out some way. And then I gave it to you. So.
And Dr. Lee, there's also put in the comments that there's several comments asking how they can access information about signing up to participate in the studies. And I'm assuming our study.
Were you going to answer that, Kelsey, in the?
Um, I think for Dr. Lee and I's clinic, it's an in-person clinic. I don't, Dr. Lee, if you want to speak to like, do you have to come to clinic in order to participate in the study piece?
Yeah, a good question. So technically, so I think the short answer is no. I think there is a way where we can possibly consent families virtually for this. I will say the studies that we don't, for example, have a specific research coordinator or someone, let's say, who's like dedicated solely to helping to coordinate things like that. And so this basically has, because of that, that has to be basically kind of arranged, likely with Kelsey and myself. And so some of this is actually a little limited, honestly, by a bit of time and in terms of being able to kind of get that going. And I know, we are, my long-term goal, I'm hoping, is to be able to, obtain some funding at some point where we can have someone that is more dedicated to helping with assist with things like that, because it is not something currently in our capacity that we can do currently, like regularly for everybody, if that makes sense. So yes, I echo Kelsey in that's I think part of the reason why it is easiest in the sense of getting a lot of the paperwork done, the formal consenting and things when patients are in our clinic. But also I will say, actually, I'm going to be stopping by the SOF conference later in July this year. So for example, we were able to meet a number of families last year at last year's conference and kind of consent them there as well. So that's another option for families, for anyone who was interested in participating. A little bit of to be determined on that end. And I apologize that we are not in a place where we have a bandwidth to, just be able to consent to anybody. It just requires some more time, and it's just a little bit limited because of the number of, I would say, clinical responsibilities that both of us have already.
Thank you. So I think, Mindy, you and I have talked in the past, and I don't remember. I don't think we resolved it completely, but I did mention to you that you and Kelsey could apply for a small grant from SOFT. They're usually in the $5,000 category. And I know that probably isn't enough to really get a study coordinator going. It might be enough, given what I know biostatisticians charge per hour, at least at our place, $150 an hour to get a consult from that core here at the University of Utah. You might be able to get the biostatistician to help you with growth data. But as far as more comprehensive data, not sure $5,000 will get you the part of the equivalent of the study coordinator that you need, but it might be some stuff.
Yeah. Yes, and the other thing I was going to say is, because this question has come up and is personally related. In an ideal world, I would honestly just be able to offer telemedicine for an actual visit and consult and things like that. And then at the same time, you could discuss things like the study and at the same time. But I, unfortunately, I just wanted to explain the reason why we actually can't offer that has to do with the laws, the state licensing laws. For any clinician, for physicians, essentially. So essentially, physicians that you see, they have to be licensed where you live, in the state where you live. And so those are the rules are pretty strict in Illinois. Sometimes we even have difficulty with families crossing over from other states that are nearby and things like that. But that's the reason, apologies, that the clinic, for example, right now, the initial visit at least has to be in person. There's just no way around it. We are not allowed to offer the new visit, like telemedicine visits, for new patients out of state in this manner. But then once you are seen, sometimes you can have some, a little intermittent follow-up by telemedicine. That's another option. But so hopefully things will change with time. It takes a while to get some of those research changes going.
So in the interest of our time, there are two questions that Dr. Lee and Ms. Hogan and I had a chance to talk about before we got started, partly why we were a few minutes late. Well, one from Michelle and one from Susan. They actually have a fair amount of overlap. And I think we can do our best maybe in the next, very excellent questions. They're really important. And we'll do our best maybe in the next 10 minutes, but then it would be, there's another question online from Hannah that'd be good if we could possibly tackle as well, because I think it's a good general question for everyone. But maybe we'll see what we can do with Michelle and Susan's questions related to a partial 9P more than trisomy that's complicated. So I'll read this slowly so that, and maybe what we'll do is we'll go down, we'll do the first three because they're all related to the study, to the microarray study or the karyotype study or mosaicism as a general question. So I'm going to put the first three questions kind of, we'll go for that first. Michelle asks, cytogenetic microarray. She abbreviates it appropriately as CMA, but cytogenomic cytogenetic microarray. Genetic testing showed that our grandson had 9P, these are the bands, 23.3 short arm P, 13.1 non-mosaicism. But follow-up karyotype, which is a chromosome study, 4 months later, which tested 75 cells, the right thing for them to have done, showed tetrasomy 9P mosaicism. Maybe, Mindy, you could define that as we go along. How could the microarray test be so inaccurate? We were told that if a child is mosaic, the microarray test cannot easily differentiate between trisomy and tetrasomy. Maybe I'll stop there at that point for the first and second question. So the question was basically in summary, how could the CMA microarray test be inaccurate, especially when it's thought to be the first tier test? And we were told it couldn't differentiate necessarily between trisomy and tetrasomy. You might distinguish, Mindy, what the trisomy versus the tetrasomy means, but.
Yeah, I was going to say, actually, I was going to ask if Kelsey wanted to
Sure.
kind of initially provide the background, because it was a really, really good question, just because of kind of the amount of technical information that I'd probably helpful to have a little bit of background. Yeah.
Yeah, we'll go a little bit even farther back. So as a reminder to everyone, a microarray is the test that looks for extra or missing pieces across all the chromosomes, things that we cannot see with the naked eye. So you're not using a microscope to do that test. It's like a computer chip. And a karyotype looks at the chromosomes under a microscope. So like a person is visually looking at them and making sure that they all look correct. And you can miss small pieces of chromosomes that have differences in them. So the biggest question is like, well, why didn't we start with a karyotype? Is because our technology, the microarray, is truly better at catching things that are missing or extra that you can't see with a naked eye. But trisomies and tetrasomies are commonly big enough to see with the naked eye. It's just not always the test that we start with when we don't really know why that child is presenting with all their medical concerns. So we start with the microarray, and then sometimes we go to the karyotype to kind of figure out what exactly are the chromosomes doing. And we can see a trisomy or a tetrasomy with the naked eye. So that's why we go to it as the second next step. Now, to define trisomy, remember that's referring tri is 3. So we should have 2 copies of our chromosome 9. Trisomy refers to 3 copies of something. So mosaic trisomy 9 is referring, or trisomy 9 is referring to 3 copies of chromosome 9. When you start throwing around P and Q, you're talking about portions of the chromosomes. So because they orient themselves or organize them by their arms, their short arm and their long arm. So 9P or trisomy 9p is 3 copies of the short arm of chromosome 9, and tetrasomy is 4. Tetra means 4. So you have 4 copies of the short arm of chromosome 9. And what we know is that there is no perfect genetic test. So when you have some different cell lines, is the fancy term that we use, but basically a genetic change that there's more than one of them in some portion of the body, where you can have one type of genetic change like tetrasomy 9p, or in some other parts of the body that you test can have just trisomy 9p. We know that mosaicism can exist, and that different tests can pick up different amounts, whether it looks mosaic or not mosaic. And even if you were to repeat tests, they can have differences in those repeated tests as well. So I hope that was kind of a good, at least basic refresher of what all that terminology was, and kind of getting at the difference between the tests and why sometimes there can have different results. Dr. Lee, is there anything you'd like to add?
Yeah, just echoing that tests are not perfect. And at the very end of the day, that chromosome microarray still can technically pick up more than a karyotype. And actually, my earlier studies looking at specifically the trisomy 9 mosaic patients, all of their diagnoses were picked up on a chromosome microarray, but many of them were missed on a karyotype. So now this is different from the specific change that's being asked in question, because a trisomy 9 mosaic individual would have basically a full copy of the entire chromosome, not just like a piece, as some of the parts of the chromosomes that Kelsey was explaining, you have short arms and long arms and things like that. So that's why but for that particular condition, for example, that's what we found in that data. But I can definitely see how smaller things can be missed, and it's just we've seen errors happen. I mean, it's not super common, but just things can happen on the lab end, and they're not perfect. Even our current most comprehensive test right now, I will say, is not perfect. It's just something we'll have to wait as the technology gets a little bit better.
On the same line, and thank you for that combination of clear explanations from both of you. On the same line, Kelsey already implied some of this. If a child is 70% mosaic in the blood, we'll say for 9p, the two nines, p's attached together, that doesn't provide much insight, as it could be that the skin, other tissues, organs all have low or higher. And just to summarize, 40 years of thinking about this, like this is like the enigma or the puzzle, or maybe even the curse of mosaicism, that it's so hard to even correlate which tissue you have, what percent you have, and how the child fits the syndrome we're talking about. Maybe I'm giving a preamble to what both of you might say, but so comments on that idea of having 70% doesn't provide insight as to the other tissues.
Yeah, it definitely does not provide insight. I would, for anyone on here whose child has had this, whatever testing was done, if it was one of the ones where it's providing, this percentage of, mosaicism, there is no correlation to what that sample was to what you see. That was one of the biggest questions I had when I looked back at my initial cohorts, and there was just no, it did not match up. So just because you have a higher number doesn't mean it's going to show more features versus lower. That it's just because you get a very small snapshot of the testing is typically done off of blood, and it can be done off of other samples, but that's probably the more common one. And it just depends on what you get in that blood at that moment, which is why it can vary so much. And she'll have the excellent insight of, yes, you were right. You don't know what's going on in the brain. But it's unfortunately something you can't test. And there's pretty much other organs in the body, you really just can't go in and test them. And so that's how we can't really tell. And so, it's, just we try to tell families, not to focus so much on that number, because at the end of the day, all of it tells us is that there was, yes, something, some cells that have that change, or some building blocks that have whatever the change is, and some that do not, if it's like in this mosaic form.
Thank you. So Michelle and Susan, which has a quite similar question, both ask about why do children with trisomy often have problems with body temperature regulation?
Okay, yeah, that's an interesting one. I have not seen a lot of individuals with, well, okay, so there's different kinds of trisomies. If we're talking about specifically, let's say with like the trisomy 9 subgroup, I will say I personally have not seen a lot who have reported that concern. That doesn't mean it's not happening, but just in the patients that I've seen. But again, everyone has a little bit different. Even if you have the same types of genetic changes, patients can vary quite a bit. So that's not just something I have seen. I do see, though, that there is another question after about, partially related, about sort of, why can't, this seems to affect like the proteins involved, and why can't you basically use some methods to try and kind of prevent so much of these things from being made. I think for that one, I will say, so the 9th chromosome, I mean, has a lot of genes, and they all do different things. And the biggest thing I will say is genes are different. They have different ways that they work. So, for example, there may be some cases where some genes, where it basically affects them more if there's a lot more being produced, and in other genes, maybe less so. They're less so affected. Some of this also depends on where the change is and what's involved there. And so, that's why you can't always just kind of make a treatment to kind of stop things from being made. It's very hard to target these things, is the other piece of it as well. It's hard. You can't just go in and target the entire chromosome, because that might help for one portion of the genetic instruction, but if there's another gene that could basically possibly cause other issues or side effects. For example, let's suppose, there is something here that's affecting, let's say, the body temperature regulation. Could you go and do something to kind of suppress that or keep it from working? Well, theoretically, possibly you could do something like that, but then maybe that would also have an impact on something else. So sorry, those are just my kind of long thoughts, kind of related to that general overall question of like, well, if you have this issue, concern or problem, why couldn't you address it this way?
And maybe both you and Ms. Hogan, Mindy, saw reports a few weeks ago about using gene editing to take cells of a person with trisomy 21 Down syndrome and to basically edit it out so that they now only had 2 working copies of the 21 rather than 3. But as you're already pointing out, it's much more complex than the press releases made that seem, because of course, both in trisomy 9 mosaicism, 9p tetrasomy mosaicism, and Down syndrome, so much of what the extra gene dosage affects occurred before birth. And so after birth, I'd like to think that maybe we can affect developmental milestones, but it's exactly what you said about what's complicated, and certainly the birth defects that would occur in any of the conditions we're talking about already would have occurred. Now, we don't even have time to begin the sentence to discuss, well, what about in utero therapy? We're getting close to the end of the hour, so we obviously can't have that theoretical discussion, but you can see why it makes sense that both Michelle and Susan were asking that question. But I have to, we haven't closed yet. We still have 4 minutes, but I couldn't resist the comment, and this involves the three of us and everybody at SOFT and everybody with any trisomy. It seems like there are no researchers and no NIH grants to further explore and set up trials for trisomy 9. And I think, just going to say, as someone who's been interested in chromosome conditions for so many years, once the single gene community came into existence, all of the funding went toward, well, we'll see what we can do about this single gene or that. And so in some ways, I share with the questioners that chromosome conditions, which by definition will involve many genes, sometimes more than 400, I share that there isn't a lot of NIH research. Parenthetically, we're all on our seats about NIH research. But that aside, there aren't clinical trials on chromosome conditions if you look at clinicaltrials.org. So I think the three of us would share the lamentation that for rare disorders, there's not as much focus on chromosome conditions as we would like. That's why you would have difficulty, Mindy, seeking funding for even your natural history study.
Yeah.
You know, NIH in full bloom, you're still going to have a hard time getting funding for that. But
Yeah.
There was question, I think, just in our last, you can't do this in 2 minutes, so it might be that you do the best you can, from Hannah. And maybe we'll just try to do question number 1 because it answers a lot or addresses a lot. Is there any evidence that ABA therapy has helped improve problematic behavior in kids with trisomy 9?
A great question. I have this type of therapy is not something actually I've seen a ton of families actually have used. Some of this it's common. It's typically more commonly used, for example, in individuals with additional diagnoses of things such as autism. And difficulties with behavior and things like that. But that being said, nothing's been published specifically with this group. But we have seen maybe for anyone who might be having some difficulties with behavior and such, we have seen, just personally from seeing other families who've used it, a lot of improvement. I feel like generally most of our families note some type of improvement. So if that is of a concern for anyone, for their child, I certainly don't think it hurts. We just don't have the specific long-term data on it, but we know it can certainly help in other situations. So I don't see why that wouldn't help for this group of conditions.
Thank you. Well, I think we're actually at the end of the hour. I think one thing that Dr. Lee and I, Kelsey, talked about was that Lisbeth sent a question in Espanol. Lo siento, we weren't able to get to that question, and I think Mindy, you were going to try to answer that question because we have her email.
Yes. So. Hola Lisbeth, no sé si estás escuchando, pero hablo español también y vamos a tratar de contestarle a tu correo electrónico sus preguntas, ¿ok?
Gracias. So I think I think though we didn't get to every aspect of every question, and I'll take the moderator's prerogative to have tried to be selective as what would answer the most number, and we apologize even now. But we also are so grateful for so many provocative, stimulating, and excellent questions. Any other closing remark, Mindy? I think you answered at least in terms of the study where we are now in how people might be able to participate and what your limitations are by just not being able to do the virtual meetings outside of Illinois. So
Yeah. So, I think both Kelsey and I probably just want to say thank you guys. Thank you everybody so much. Yes, for just, for taking time out of your day to, submit questions and to just be here and to be willing and actually part of just this community to kind of share your information, because the only way we learn is actually from families, because what we learn from families like yourselves. And that's the only way we can help additional families. Truly, I'm sorry we couldn't get to every last question that was asked, but we did our best to kind of, answer what we could. And we hope to, meet some of you later at another time, whether that's in our clinic or, at our Future Self conference or in some other in some other way that we can meet. For those families out there who have already met me, hello. Thank you for joining tonight. Yeah, Kelsey, anything else to add as well?
No, you're stealing the thunder. Great summary. I'm so happy to be here. I feel like I've talked to a few of you already just with interest in our clinic, but if any of you reach out, I'm happy to answer questions. We have a clinic website at Lurie. I'm just gonna say that I drew that chromosome 9 myself, so it's beautiful. So I'm here to help answer questions about our clinic, our research. And thank you so much for having me today. Happy Trisomy 9 Day, everyone.
Yeah.
so Kelsey,
Yeah.
is your email on the website?
Our main phone number is, and it
Okay,
typically, if
good.
you call in, it gets triaged to me, and I would either call you back, or if you specify when you reach out to our genetics team that you would like an email back, I could do that too. But we typically, my email is not, but I can give my email right now if that's helpful. Or I
If it's
can
okay
have,
with you.
yeah, I can have Kelly put it in there. It's K, my first name. E is in my middle initial, and then my last name, Hogan, Hogan, at luriechildrens.org. And that's LURIE, children's with an S.org.
And no space between Lurie and Children's, right? Or no.
Nope, all one word.
Oh, very good. That was nice. And
Yeah.
also to remind everyone, Dr. Lee is attending the SOFT conference this summer, July 11th to 13th in Indianapolis, and we'll be also giving a workshop there, and we'll be there. And so
Yes.
again, I think we went over time, and we do thank everyone for the fabulous questions. And we all three of us apologize for those that we weren't able to address more in detail.
Yeah. But yeah, thank you all so much for participating.
Yeah. Bye.